Well, again, thank you and welcome. This program is sponsored by the CME Outfitters, which is an award-winning CME program globally. The program is about what you see on the screen, what the future holds for NASH, an augmented reality look into the disease staging and targeted therapy. I am delighted to actually be joined by two of my colleagues here, Dr. Rohit Lumba. Rohit is, of course, an internationally renowned hepatologist with a lot of experience in NASH and NAFLD. He's the director of the NAFLD Research Center at UCSD. He's also professor of medicine, director of hepatology, and vice chair of the Division of Gastroenterology. Well known to all of us, and I'm sure all of you. So it's great to have you here, Rohit. Thank you.
Thank you. So very delighted to be here.
And we also have Mazen Nuruddin, who is another wonderful friend and colleague and very well known in the area of fatty liver disease. He is at Cedars-Sinai. He's the director of the fatty liver program at Cedars-Sinai and has been extremely productive over the last few years and contributing in so many different aspects of non-alcoholic fatty liver disease. So Mazen, it's wonderful to have you. Thank you.
Thank you very much for having me.
So what we're going to do in the first part of this is to just talk a little bit about the epidemiology and then also about the pathogenesis of the disease. And again, it's going to be interactive between us, but also with all of you. And what I like to do is to actually start with a case. This is a typical patient that all of us see in our clinic, at least in the United States, 59-year-old Mexican-American male, referred by a primary care physician because of elevated liver enzyme. Statins for this lipidemia was stopped about 3 months ago. The patient has a history of type 2 diabetes for about 5 years, history of dyslipidemia for about 2 years, and there is a family history of diabetes and hypertension. There is not a lot of exercising. He walks his dog occasionally. He's an attorney, by the way, I think a medical litigation attorney, so you got to be very careful with that in the United States. Drinks occasionally, about 3 drinks a weekend, but then during the weekdays when he goes to a dinner, he has a couple of drinks and maybe wine with his steak. There is really no symptom except for this vague right upper quadrant abdominal pain, maybe a little bit of fatigue. He takes metformin and fish oil for his dyslipidemia, and someone told him it's a good supplement to take. His examination is completely normal except for visceral obesity as well as a BMI that would qualify him to be obese, at least in this country. His liver enzymes, as you can see here, are just very, very mild, minimal elevation of aminotransferases. His platelet count is normal, and of course there is some dyslipidemia with triglyceride being about 240. His HDL is 40. His LDL, just because he was treated on a statin, is about 100, and his hemoglobin A1C is 6.9, with slightly outside the range of normal. Now let's actually talk about why do we actually need to pay attention to this patient and what's happening to these to our population all over the world. And let's consider the prevalence of non-alcoholic fatty liver disease. The prevalence of NAFLD worldwide is about 25%. The prevalence actually varies across the globe. The highest prevalence is Middle East and South America, and the lowest prevalence is in Africa. So when you look at United States, North America, and Europe, the prevalence is about the same. It's about 24% or so. One of the highest prevalence that, at least when you adjust for BMI, is from Asia. In fact, there is a meta-analysis that was published in about the last couple of months from China, suggesting that the prevalence of NAFLD in China is about 29%. Higher in the area that are urban, for example, around Beijing and Shanghai, which is probably related to sort of the diet and the lifestyle that they have. But it is also a very high prevalence in Northwest China. That's probably not related to this urbanization that we are talking about. That probably has to do with diet, specifically very high salt diet. Now, when you're looking at the prevalence of non-alcoholic steatohepatitis, and we'll talk about this distinction in the next few slides, you can't really actually biopsy general population, but you have to estimate that. And that estimate is between 1.5 to 6.5%. I actually use a number of about 2 to 3%, and the general population will have NASH. And of course, there is probably a gradation of that as well. When you look at the sort of projection of what's going to happen in terms of NAFLD over the next few years, both in terms of advanced liver disease, whether it's advanced fibrosis, or complications of cirrhosis, there is a substantial increase in the number of patients that are going to have advanced fibrosis in NASH or complication of NASH by 2030. In fact, it's estimated that 800,000 deaths, 800,000 extra deaths will happen because of non-alcoholic fatty liver disease. This is from a Markov model with a decision model that both Rohit and I and Arun Sanyal were a part of with some of the other colleagues that we have here. This is not unique to the United States. The same data is replicated in Europe. It's replicated in the Middle East and Asia, and you see the same trend across the globe. So I'm going to give you a little bit of natural history, and the numbers are not really all that important. But in general, we think that non-alcoholic fatty liver disease is a spectrum that includes NAFL, without a D, that you have on the left, and that's the subtype that is progressive but a much lesser sort of rate. Those patients can go actually into NASH, but NASH can regress to NAFL. But some patients with NASH, about 20% or so, can progress to more advanced stages of fibrosis and will be at risk for complications. There are two things that are actually very peculiar about this disease. One is that the progression is not linear. You have periods of time where patients actually progress, that's followed by regression. It's called spontaneous regression. In fact, you see this in clinical trials in the placebo arm, where you have 10 to 20% placebo effect. That is spontaneous regression of fibrosis. It's very important because that makes this disease very difficult to treat with the randomized clinical trial of new drugs. The second peculiarity of this disease is that except for hepatitis B, most of the HCC that we see in the world is related to cirrhosis. Well, in non-alcoholic fatty liver disease, you can develop HCC in the absence of cirrhosis. When you look at the rate of HCC in the cirrhotics with NAFLD, that rate is about 2% or so, which is about half of what you would see in hepatitis C-related cirrhosis. When you look at the rate of HCC in the non-cirrhotics, it's about 0.5%. So it's actually much lower, meaning that you really are not capable of screening those patients because it doesn't meet the threshold for cost effectiveness. So patients with bridging fibrosis, that they can progress, and there are a number of predictors of that. Some of them are non-invasive tests, and Rohit is going to talk about the ELF testing, and there are some others ones, NAFLD fibrosis score. In general, clinical predictors of progressive liver disease is probably type 2 diabetes. Histologic predictor of bad outcome, both progression in terms of fibrosis, but mortality specifically, the stage of fibrosis. Rohit, myself, and a few other people actually have done this, and there's a meta-analysis that can show this. And of course, when you're looking at what actually are predictors of hepatic decompensation, some of those are common in other liver diseases. But again, you can have actually some score of non-invasive tests that can tell you that these patients are at risk for more events in terms of decompensation, and Rohit is going to cover that. One peculiar population that we need to really pay attention to are the diabetics. This is a meta-analysis that was published in Journal of Hepatology recently, looking at the prevalence of non-alcoholic fatty liver disease in type 2 diabetics. That prevalence is about 55%. If you biopsy type 2 diabetics, the prevalence of NASH in that group is about 37%. So very high prevalence of NASH in this group. Now, it's not only that NAFLD and NASH are common in this group of patients. Progression, as I mentioned, in terms of cirrhosis is high in this group. And in fact, diabetes is an independent risk factor for hepatocellular carcinoma. If you look at all kinds of liver diseases, diabetes always counts as one of the independent risk factors. And that, of course, that's also true for non-alcoholic fatty liver disease. So, when you look at the progression of this disease, when you look at high prevalence that you're seeing across the world, this is probably a very, very complex disease that includes not only genetic predisposition, but also environmental factors. In environment, I consider them a number of things, but including diet, exercise, and other sort of environmental toxins that we're exposed to. What I'm going to do is actually ask my colleague Mazen Nuruddin to come and give us some of his own data about diet and what component of the diet can actually cause more NAFLD and potentially progression, and then really get into some of the other pathogenic pathways, including some of the genetic things. So Nuruddin, please go ahead and actually give us some insight.
Dr. Younasi, let me just take a look if they finish their plates first. All right. Sorry to make you feel guilty. For those that did not finish their plate, hurry up before I finish the slide. So this is a study actually coming in Hepatology, or it's in PubMed already. This is a large study we did. It's an epidemiological cohort. We have 3,000 cases of NAFLD. And this is important. We broke it down by cirrhosis and non-cirrhosis cases. So we had around 500 cases of cirrhosis and 2,500 without cirrhosis. And we had a very large, actually, match controlled, almost 30,000. And this is the bad news, which we know already, that if you eat more food rich with cholesterol, you increase your risk for NAFLD with cirrhosis. And the odds ratio were much higher. We put some salad in your food today because if you eat fibers, actually, it's protective of NAFLD with no cirrhosis. And you have been hearing the news, all the debate about red meat and processed red meat. The study confirmed previous studies that came in JHEP, showed that total red meat, not just associated with NAFLD, it's actually associated with NAFLD with cirrhosis. So that's very important. Processed red meat was associated with NAFLD without cirrhosis. And unfortunately, we had chicken tonight, and we avoided the red meat, but chicken also was associated with NAFLD, no cirrhosis. So very much, a lot of what we ate today can lead to NAFLD, but we saw the bad ones that lead to cirrhosis, especially cholesterol and red meat. So now, like, it's evolving, the diet is evolving, and we know what can lead to cirrhosis and not cirrhosis. Let's talk about the pathogenesis. You guys all know this, but simple concept. Let's look at the left. Dr. Younasi alluded nicely how the pathogenesis start. Like the disease spectrum, NAFLD, he said we take out the D. So that's NAFLD, the beginning of the disease, when the fat goes into the liver. And when this process happens, 3 things or 4 things happen. First, you see the food there, the burger, increased food intake. That's one of the factors that lead to increased fat accumulation within the liver. Then within the liver, you see this DNL, increased de novo lipogenesis. That this is important pathways. And a lot of drug targets target that pathways. So Dr. Lumba Younasi and I later will talk about mechanism of drugs. A lot of them hit this de novo lipogenesis pathways. So keep it in mind. And then you have increased free fatty acid delivery from the adipose tissue. Eventually, there's less beta oxidation in the mitochondria. The triglyceride does not get excreted as VLDL. Now you have the fat stuck in the liver. Luckily, not everyone goes to NASH. We know that this disease is very prevalent, but some people go to NASH. And the people that go to NASH are subpopulation. And we used to call it the second hit hypothesis. Now it changed. We call it the multi-hit hypothesis. So you get oxidative stress, increased iron, microbiota, mitochondrial injury, J&K and KR stress, and of course, genetic factors. And one of the hottest 2 areas that we're talking about now that we saw in this meeting, the microbiota. Dr. Lumba gave a talk. We had a section in this meeting. So let's take a look. This study actually came from Dr. Lumba's study center. And it was a very good study that they looked at around 150 patients with NAFLD. They were stratified by MRI PDFF, that they looked at the fat, and MRE, that they looked at fibrosis. They also had validation cohort. And they looked at gene associated with steatosis and fibrosis, and especially the microbiome genes and metabolites. And they pinned it down to 56 metabolites. Out of those, 6 were microbiome metabolites. And then this was this one in particular, 3-hydroxyphenyl lactate that was significantly associated with the steatosis and fibrosis. And if you track this down, it was actually associated with bacteria in the literature that was associated with advanced fibrosis. So there's increased evidence that microbiome plays a role in non-alcoholic fatty liver disease pathogenesis and even the fibrosis process. Also, his group has showed that microbiome can play a role as an accurate biomarker in this disease, and more is coming from that group. The genetics plays a significant role. I'm not going to go through it, but all of them. But you heard about the PNAP3. The PNAP3 is an important gene that has been associated not just with NAFLD, but also with the severity of the disease. Its role, it's still being defined. It's in the liver and the adipose tissue. It's associated with lipid metabolism, especially the SBRPP, and it's still being explored. There's another important gene, TMSC6SF, that is associated with fibrosis. So as you see here, we're talking about genetics, microbiota, that all of them lead to secondary hits that play slower in the steatosis and the fibrosis factor. And that's how I told you about the environment as well as the genetic factors and the microbiome in this disease.
Wonderful, thank you. Thanks, Mazen. That was very interesting. And I think what couple of things we were going to do is to actually, I'm going to show you some questions that's going to have some audience response, and you can go ahead and actually pick those answers. If we have time at the end, we can actually start discussing those things, but if not, during Q&A, hopefully we'll get it to some of these questions. Let me go back. Can we go back to the question? Okay. In what proportion of your patients at risk do you screen these patients for non-alcoholic fatty liver disease? For example, patients with type 2 diabetes, dyslipidemia, etc. So let's go ahead and actually vote. Let me just talk to you about the clinical presentation of non-alcoholic fatty liver disease. And this is, as you know, a disease that is pretty asymptomatic. Most of these patients can have symptoms that are pretty mild, fatigue being one of them, right upper quadrant discomfort being another one. I have to tell you that until just last year, I was under the impression that it's completely asymptomatic. The information that actually we have received recently that show me that this is actually not an asymptomatic disease came from patient-reported outcomes, questionnaires that are validated. And you see that about 30% to 40% of these patients have fatigue. Very, very common, actually, symptom if you ask the patients. Now, of course, this is a disease that you have to exclude other causes of chronic liver disease. Hepatitis C, genotype 3, as you know, causes fatty liver disease, which is I call a viral-induced steatosis. Alcohol, of course, you have to exclude. And of course, it is one of the most common causes of chronically elevated liver enzyme. Let me get to some of the questions that came through the iPad. First, is there a difference between gender? When we started studying non-alcoholic fatty liver disease in early 1990s and late 80, I think it was 89, it was supposed to be more common in female patients than men. That flipped over time, at least in terms of progressive liver disease. So I would say that there is probably a bit of a male preponderance in terms of the progressive form of non-alcoholic fatty liver disease. So that was one of the questions that the audience asked. Another very important question is that it's really the incidence of fatty liver disease is going up, or it's just because we are recognizing more of this, and that's why we are actually seeing the high numbers and the prevalence. And today, actually, there was data presented by my team on global burden of disease, which is actually GBD with about 21 different regions of the world, 7 super regions of the world. And when you look at all the regions of the world and you define NAFLD, there is actually no doubt that there is an increase in the prevalence of NAFLD across the world. And it parallels that of what we know in terms of obesity and type 2 diabetes and other complications of metabolic syndrome. And one other issue that we not actually discussed here, which is very important, is about lean NAFLD. And the question was specifically about Africa. I have to tell you that there is not a lot of data from Africa. I can tell you that lean NAFLD is common, and especially in Asia. In the United States, the prevalence, there was another actually oral presentation this morning about lean NAFLD in the United States. It's probably around somewhere about 7 to 10% is the prevalence of lean NAFLD in the United States. So it is not a benign disease. It actually, when you look at completely metabolically normal NAFLD, meaning lean and not having any metabolic components, then that number is actually very, very small. Most of these patients have some metabolic abnormality. On the other hand, if you actually go to an area, like rural area of India, maybe that's not all related to metabolic abnormality. Maybe that's where, as Mazen, you talked about, that dysbiosis may be playing a role in some regions of the world. One question for you, Mazen, that came in was about artificial fiber. Either one of you, is there actually any role, any protective role when you're looking at the artificial fiber?
Yeah, so the study showed that fiber is protective from non-alcoholic fatty liver disease for sure. We didn't break it from which source of food and all that. This is something to do. But I mean, the study made sense that cholesterol in multiple animal studies increased with fibrosis and all that, and fiber was protective. So we need to do more work in terms of the source of the fiber. But in general, an increased fiber is protective of non-alcoholic.
So is it because of change in the microbiome? Is it because of the changes of the lipid profile, or do we know any of that?
It is a great question.
Yeah.
This is epidemiological association study, as you know, so it is just a observation that we did. I would say probably all of the above. If I want to speculate what the mechanism, change in lipid metabolism as well as the microbiota, but more studies need to be done in terms of like mechanistic. What's actually the exact right mechanism for fibers? I'm
going to ask Rohit this question because he's done some work on microbiome.
Yeah.
Tell us if the changes that you see in the or the dysbiosis that you see in fatty liver, is it related to fatty liver? Is it related to obesity and diabetes, or is it related to gut dysmotility that you see in a lot of these patients? What do you think?
Yeah. Thank you, Zubair, and thank you, Mazen. We've looked at patients who are obese, so it's clamped for obesity, and then compared those who have mild NAFL and compared with advanced fibrosis, so stage 3 and 4. So there's a clear difference in terms of your microbiome, both on what's in there, which is 16S, and what's the function of that microbiome is also different. So from normal to NAFLD, there's a difference in microbiome, and that's not linked to obesity, although the association with obesity is closer. But there's a clear difference in those who have advanced fibrosis, which is stage 3 and 4, versus stage 0 to 2. And the pattern that's emerging is that you have oralization of gut microbiome, which means the oral bacteria that's supposed to be in the mouth, they start traveling towards your colon. And you're also seeing more gram-negative bacteria that are becoming predominant, especially proteobacteria, which are about 3 times higher. We knew this in patients with cirrhosis and hepatic decompensation earlier. That's why we were using therapies like fluoroquinolones that treat E. coli and Klebsiella. But we're finding that those bacteria start emerging much earlier than hepatic decompensation. So that's one feature that's consistently observed. Recently, we found that you could detect microbiome based upon you could detect cirrhosis based upon a metagenomic signature from stool. And the really unique thing in this particular study, which will be presented on Tuesday at 9 a.m. in translational plenary, is we got a signature in San Diego among cirrhotics with NAFLD. And then we were able to download data from a Chinese cohort from 2014, published in Nature, and validate our signature from NAFLD cirrhosis in the Chinese cirrhosis cohort. And that cirrhosis cohort had patients with hepatitis B, alcohol, hepatitis C, and some NAFLD as well. And then this was a surprising finding. We didn't expect it to happen because in no other disease, this has been validated that a signature, say, in coronary disease or diabetes is validated in China. Then we were able to validate the same signature in an Italian cohort as well. So I think it's clear that cirrhosis definitely has its own microbial environment. Whether it's a cause or effect is unclear.
Yeah.
But for now, at least, it could be potentially used as a biomarker.
Fantastic. No, I think this is the cutting edge of technology that you're using. And I'm a big believer that it's probably what we eat, not only directly, but indirectly through the antibiotic use in our meat, at least in the United States. You know, chicken that we eat probably has a lot of antibiotic in it, and milk and other things that probably changes the microbiome sort of composition. Now, I'm not going to talk about liver biopsy, but I'll ask Rohit to talk about not only liver biopsy, but all the non-invasive tests. And you're a leader in this field. Tell us about what is actually exciting, and then really most importantly for all of us, in 2019 and then in early 2020, how do you use these non-invasive tests in a clinical setting to risk stratify patients, primarily enrich patients, because you can't really do screening general population right now.
Correct.
But how do you actually risk stratify and link those patients to appropriate care? It's yours.
Thank you, Zubair. So our patient has elevated ALT and AST and is coming to our clinic. How do we decide that this patient needs a biopsy and the other one doesn't? And some of the thoughts that go through my mind when I'm seeing that patient in my clinic is, what are the features of metabolic syndrome they have? Greater the number of features, higher the likelihood of NASH or fibrosis on the biopsy. And the main idea that you have is whether my patient has fibrotic disease or advanced disease or not. And if I could pick certain risk factors and then do a liver biopsy in those who I think would be at high risk. So obesity, hypertriglyceridemia, low HDL cholesterol, impaired glucose tolerance, or diabetes. AST to ALT ratio is important. Our patient had an AST of 65 and an ALT of 60. What that means is there's reversal of ALT to AST ratio. This could happen in a few settings. One setting would be in the setting of alcohol use. We think our patient is consuming alcohol, so you may ask the patient to stop alcohol. The other possibility is that the patient has advanced fibrosis, and that's why in this particular setting, I end up proceeding with a liver biopsy. Low platelet count, especially near normal, about 150, that would be a risk factor for having stage 3 or stage 4 fibrosis. Borderline low albumin levels. And then if you have these risk factors and a patient is going for cholecystectomy or bariatric surgery, it would be reasonable for you to call the surgeon and say, we should consider a liver biopsy at the time of bariatric surgery. Older age, diabetes, and family history of diabetes are other considerations. But there are disadvantages of the biopsy, such as sampling variability, pain, infection, bleeding. And in general, patients don't like getting a liver biopsy, and they would rather avoid the need for getting a biopsy if we were to have a reliable non-invasive test. In the next slide, I'll show you a panel of things that are either available in research or clinically that, as clinicians, we sometimes use. How to exactly use them, we'll discuss in the next few slides. The way I've listed them here is you have the clinical labs to the left, imaging modalities in the middle. Ultrasound is routinely utilized, and typically you might see a fatty liver on ultrasound. But if you do not see, or a radiologist doesn't call it to be echogenic or fatty liver on ultrasound, doesn't mean the patient doesn't have it, because it's not a very sensitive test. So if the fat content of the liver was between 5 and 15%, ultrasound may be negative. So understanding that, I think, is important, and this may occur especially in the setting of cirrhosis. So rarely you might find a patient report as a normal ultrasound, although the patient may have advanced fibrosis or cirrhosis. So just for caveat. And then the other imaging modalities, especially those related to elastography, we're going to be discussing a little bit later in greater details, and we'll sort it out how to use them. Other biomarkers that are available, either together or as a panel, are listed here as well. We'll discuss 2 or 3 of those that are potentially either clinically available or might become clinically available in the next several months. One of those is FibroSpect. In this particular study, what we did was we evaluated whether FibroSpect can differentiate patients with advanced fibrosis, those who have stage 3 or 4 fibrosis, versus stage 0 to 2. It includes 3 markers, alpha-2 macroglobulin, hyaluronic acid, and TIMP1. To the left, I'm showing you data from UCSD cohort, and then also a validation from Duke University cohort. And what you're finding is that FibroSpec gives about a diagnostic accuracy of about 85%. And towards the right, I'm showing that the red bar or the red line is the FIB4 diagnostic accuracy. And this is a clinical prediction rule. And so in terms of definitions, clinical prediction rule to me means something that's clinically available, and you can use that information to predict. Biomarker or a panel to me is something that you either order or is experimental, and those tests are not clinically available through routine lab measures. So FIB4 includes age, ALT, AST, and platelets. So that's clinically available. You put in an algorithm, it gives you a number. And we'll see how we use it clinically. So FibroSpec 2 is better than FIB4 for detection of stage 3 or stage 4 fibrosis.
So I think one of the things we wanted to do, Rohit, was to sort of get at this new test that I know it's available in Europe, but I have to just, at least let our colleagues from the United States know that ALF testing is not currently available in the United States. Hopefully it will be at some point in time. But in terms of actually using ALF testing, what cutoff do you use in terms of actually identifying a patient with bridging fibrosis? Let's actually vote first, and then we'll have Rohit enlighten us about what the real answer is. Let's go ahead and actually choose one of those options that we have.
We gave you a sneak preview in a previous slide that was 20% progression rule. So the answer is there. So here what we are showing you data from simtuzumab trials, which to the left.
I thought you were going to do the moonwalk.
It was about to. They switched out the music. So to the left are patients who had bridging fibrosis at baseline, and patients were followed for 2 years. And what you have is on top is ELF of 9.8 or less, and on top is 9.8 or higher. And those who had higher ELF at baseline had higher risk of progression to cirrhosis over 2 years time period. So that's one cut point that you could potentially use clinically. The other cut point is if you had cirrhosis, could you use a test to differentiate who would be at higher risk for hepatic decompensation in the next 2 years? And of course, we use MELD and other scores. If the MELD score is low, could you use a serum-based biomarker? And here we're showing that an ELF cut point of 11.3 in a cirrhotic is prognostic in predicting risk of decompensation. And what is that risk? Is about 20% over 2 years. Now moving on to elastography-based methods. And on this slide, I'm showing you 4 elastography-based methods. The most commonly used in clinical practice is a FibroScan, and it's an ultrasound-based elastography tool, and it's shown in the left panel top, where you can get a quantification of fat as well as quantification of stiffness of the liver. The main idea is, as a clinician, when the patient comes in, I examine the patient and palpate the liver. If the liver feels hard to me, then I think the patient may have cirrhosis or advanced fibrosis. And we are trying to eliminate the need of a physical exam, which is subjective and could differ from a physician to physician based upon training and experience, with an objective measure using an imaging modality. In this case, for the FibroScan, you're using transient elastography as a method. You get 10 readings, and they have to be reliable. There are certain criteria, and then it gives you a median of those 10 readings as your score. And based upon that, you can see how stiff the liver might be. And that stiffness is the surrogate for fibrosis in a patient walking into the clinic. There are other caveats associated with stiffness that could be increased because of inflammation, acute hepatitis, or other reasons. And so I think those should be sorted out clinically before subjecting a patient to elastography. On the top right side, I'm showing you shear wave elastography, which could be done on a GE or supersonic ultrasound. Bottom, I'm showing you RF that could be done on a Siemens ultrasound. And the bottom left is MR elastography, which is an MR-based platform. we've been trying to come up with data, if we are following patients, at what point of increase in a particular stiffness would be prognostic or would have some meaning whether the patient is worsening or getting better. This is just, this is some data that is recently accepted in Hepatology 2019. Actually, the first author is Viral Ajmera, one of our junior faculty at UCSD. And what we found was if you had a 15% increase in MR elastography, for example, if the patient started with an MR elastography reading of 3.2 today, and then comes back 3 years later, and it had increased to 4, this patient has had progression. And if I were to biopsy this patient may have one stage increase on their fibrosis score. And that's the idea. We don't have similar data across multiple biomarkers. That's what we need to generate so we can avoid the need for needing a liver biopsy for routine monitoring of our patients. I'm not saying that this is what you should do as you go back, but this is one idea that this could be potentially used. Definitely requires external validation. This is done at UCSD in one center where we do advanced imaging, but for this to be validated externally, that really requires further studies. And I'm giving you an example of a patient who actually worsened and developed a bridging fibrosis on follow-up. Now, which of these tests is better? And what we are finding is that FIB4, which is a clinical prediction rule that could be routinely available from your clinical labs, can help you rule out disease. And we think if you were to use one clinical prediction rule, there are several, and Mazen and Zobair alluded to others, such as NAFLD fibrosis score. I think you don't need to remember all those. Just remember one thing, and you could remember FIB4. And then among the ultrasound elastography-based method, I think all of them could be utilized depending on your setting if you have those availability for each of those. But if you are using FibroScan or any elastography-based method, then that is better than FIB4 in assessing if the patient has significant fibrosis or not. And then MR elastography is better than FibroScan and other ultrasound-based modalities. So this is the hierarchy of methods that we could currently use for detection of advanced fibrosis. Now, we could potentially in future combine these biomarkers where we could use FIB4, ELF, FibroSpect, and combine it with either FibroScan or MR elastography depending on the availability. And I'll give you an example in the next slide. There is new data that'll be coming out in the next year about how exactly to do it in the setting of a prospective study. Here I'm giving you example based upon my thought that you could potentially apply in your practice if you so desire. We think there are 100 million Americans with suspected NAFLD, and our goal is to identify those who have significant fibrosis. We've published previously a similar algorithm in gastroenterology earlier this year and also in Nature Reviews. So if you're FIB4, you could use this test to rule out patients who may have significant disease. And you can take a low cut point, such as 1.3 or lower, and those patients have very low risk of having advanced fibrosis. And what I typically do in my practice is you could repeat FIB4 in those patients. So you don't want to just negate it because it should not be based upon one-time testing, that over the next 2 or 3 years you can have another FIB4 testing, and that might be sufficient if you're both are below 1.3. Those above 3.25 have significantly higher risk of having advanced fibrosis. And in this particular setting, you could either see them directly in your clinic, proceed with a liver biopsy. You might even consider doing a second step. And the second step could be an elastography-based method. But if you don't have access to that, you might consider doing a ELF or FibroSpect 2. Those that are intermediate risk, I think this is one category where a second test definitely needs to be done. And I think this would be needed, especially in those that have a FIB4 between 1.3 and 3.25. And then you can risk stratify. So suppose you had a patient with a FIB4 of 2, and you ordered an ELF test or a FibroSpect, and FibroSpect is 18, and ELF is 10. That patient probably has advanced fibrosis. You need to bring that patient in, probably consider a biopsy, probably consider an intervention. That's how you could potentially use these modalities. Now, once the patient in your clinic, I think we need to make sure that there are no other competing causes for that elevated ALT and AST. If the ALT is super high, the risk factors for drug-induced liver injury, I think all those things are important as we are evaluating the patient. This sometimes gets lost because we assume that all the patients who are in the referral basket have non-alcoholic fatty liver disease. They may have other competing etiologies, especially those that are seeking care from us. So it's important to think about other possibilities that might be there. It might be 2 out of 10, but I think we should be sensitive to that to identify and diagnose them appropriately. Once the patient comes in our setting, and I think potentially in your setting as well, we're utilizing MR elastography a little bit more. Based upon data from several of our studies, we think if the BMI is 35 or higher, MR elastography works better than the ultrasound-based modalities, because ultrasound-based modalities overestimate the stiffness or fibrosis because the readings are slightly higher in this particular setting. And so we typically would recommend MR elastography if the BMI is higher. And very rarely it will fail, 1% to 2%. And if it fails, that's typically in the setting of iron overload. If the MRE reading is below 2.5, that patient has extremely low risk of having significant fibrosis, so you could potentially avoid the need for a biopsy. Especially if it is below 2, that is normal, and that patient really doesn't need any liver biopsy assessment for fibrosis detection. Now, if they have elevated ALT, you want to identify the cause, it might be different, might require a little bit more detailed history. If the BMI is less than 35, you might consider FibroScan, shear wave elastography, or RFE, depending on what's available to you. And if it fails, you might consider MR elastography. If the FibroScan is below 6, chances of having significant disease are pretty low. If the FibroScan is above 8, those patients typically in my practice would be getting a liver biopsy if we've consistently documented they have other features that are suggestive that they may have advanced disease. You might even consider doing another test such as ELF or FibroSpect, but that's typically how we are risk stratifying our patients into high risk versus low risk. And I left certain guidelines for you if you are using either the FibroScan or MRE as to cut points. Because for clinicians, we need cut points so we can make clinical decision if the patient is above that or below that. But understanding these caveats, I think, are important. Finally, to summarize this section, transient elastography, RFE, or other ultrasound-based modalities have following limitations. They don't work in these settings. In setting of obesity, you may not get a reliable read. Setting of ascites, acute inflammation, and cirrhosis. MRE may improve upon all of these except in the setting of iron overload and acute inflammation or congestion. In those settings, you will get an elevated stiffness reading. With the iron overload, there's a specific interaction on MR elastogram, and that's why you don't get accurate read. That's about 1 in 100 patients. So in terms of accessibility and ease of use and direct results that you can obtain right away, you have FibroScan, shear wave elastography, and RFE come in the center in terms of the accuracy. Highest accuracy are with MR elastography.
So before I start on sort of the new section here, the new treatment that we are going to talk about a little bit more in detail, talk a little bit about MRI-PDFF, and also one of the audience participants had a question about the cost. Are these things covered by insurance, Rohit? At least in the United States. I'm not sure about whether you would know about the rest of the world, but at least in the US. Yeah.
I think this is a very important question. So for MR elastography and also for transient elastography, now there's a CPT code in the United States. So you can use that code. For a FibroScan, typically you get, there's a facility fee and there's a pro fee. And you as a physician also get a small, in our setting, it's a work RVE of 0.25 or 0.3. So that would amount to about $25-30 for reading that scan and putting in a note. And then the facility fee is about, $70 or so. So a FibroScan would be somewhere around $100 in terms of cost or reimbursement that you'll get. For an MR elastography, CPT code that has been linked is about $250. I know that many of the institutions, especially at our institution, we typically do all of these free of cost in research setting, and also do free of cost add-on MRI PDFF and add-on MR elastography if a patient is getting an MRI. So those are done as add-on free at our institution. But that's really not the case in the rest of the country. But there is a code for $250. Rest of the world, in Japan, for example, it's much easier to get an MR elastography than a fibro scan reading or a shear wave elastography. And in Japan, the cost for an MRE exam is about $250. And the number of biopsies have reduced significantly in Japan, and they're relying more on MR elastography.
CAP versus a MRI PDFF.
Great. So CAP, control attenuation parameter, is a tool that is available on FibroScan machine. We have been working from the last 5 years to develop a ultrasound-based quantitative tool, which will be called QUS, and these data will be coming out very soon. Quantitative ultrasound, QUS. So CAP can also give you a reading for how much fat is there, and we've developed a cut point for that. It's about 288 dB per minute, decibels per minute. So at that cut point, you have an 80% likelihood that you have MRI PDFF, which is an MR-based modality, which is highly accurate with 99% accuracy and precision. The CAP gives you 80% accuracy for 288 dB per minute for detection of fatty liver disease or non-alcoholic fatty liver disease. It was proposed as a quantitative test, but really it doesn't work if you had 40% fat in the liver or 30% fat in the liver. It may not be able to quantify that. But I think for ruling in and out fatty liver disease, it's not unreasonable. It gives you an 80% accuracy, with MRI proton density fat fraction being the sort of gold standard that currently is used across clinical trials, and we'll discuss a little bit more of that later.
Absolutely. Well, thanks, Rohit. This was wonderful. Let me just actually show you some of the new treatment, and we'll have a lot of opportunity to actually talk about some of the new sort of products that are coming down the pike that you've all been contributing to. And the purpose of this slide is not to actually have anything that's actually complete. This is not a complete list. This actually slide is probably about a year old. I can guarantee you that even in terms of what has actually not been effective, and at least phase 2 or phase 3 trials that are not being moved forward. So, but it's a list that shows how active this field is in terms of drug development, and the fact that the room is full and we've got people outside shows how much interest in this field, especially both in diagnostic and treatment. Let's actually do another audience response and just get your input. How often do you enroll patients with non-alcoholic steatohepatitis in clinical trials? Never, less than 25%, 25 to 50%, 51 to 75%, or almost always 75 to 100%. Let's actually vote. All right, so this is again the phase 3 clinical trials that have been going on for a while, and I know there are a few others that are starting. So again, please forgive me if I don't have your drug here and if you're involved with this. But the 3 that have that are ongoing, the obeticholic acid, OCA, which already has had some interim analysis reported. We'll share that with you. We, of course, have selonsertib data also reported this morning, and we'll share that data with you as well. And then, of course, the elafibranor and sinequiroroc will go over all of that phase 2 and the study design for phase 3. Now, before doing this, really this augmented reality that's been put together by our CME leaders here is really just fantastic. I've looked at it. Let's actually have Mazen take us through some of the sort of targets and use the new technology. Mazen, it's all yours.
So before we started telling you that your dinner is bad, and then we talked about the microbiome, then we're going to make it up to you now. We played Michael Jackson. It's not cool. This is really cool. So let's sneak into George's liver. I don't understand pathways from that, but this is a liver. You're getting fatty liver. George is eating the fat. You're getting the fatty liver now that your liver is getting enlarged. So you start having fat accumulation within the hepatocytes. You get more fat, triglyceride accumulation, and this is the underlying pathophysiology of fatty liver. Not everyone gets NASH, but some people get inflammatory response, and you have recruitment of inflammatory cells, and these inflammatory cells started releasing cytokines, and you started getting this inflammatory mallow in the liver, and this is when you start getting NASH in the liver. And that leads, the inflammatory response leads to activation of stellate cells, myofibroblast, and you see this fibrotic liver starting to form. And look at it, George's liver is getting more fibrotic, and eventually he's going to get cirrhosis. Let's look into options. Dr. Yonasi is going to talk about FXR. So this is the FXR receptor right here. Its nuclear receptor, this is the bile acid in green, comes bind to it. And then you get that co-activator in yellow, remove the co-repressors, and stimulate these nuclear receptors. And that leads to the activation of the bile acid receptor. The bile acid receptor regulates bile acids. Bile acids, we used to ignore it back in the days. We talked about 20 years later. And then now it's coming back. We learned that it regulates lipid metabolism. It regulates glucose metabolism. And tons of data showed that it's very, very important fatty liver. The FXR agonists reduce fat, reduce inflammation, and fibrosis. And that's their role. So those are FXRs. Let's look at others. So now you have this, let's talk about other mechanisms. You have fatty liver, you get inflammation, and now I'm going to talk about PPRs. You actually start having fat accumulation in the liver. And one of the PPR receptors' missions is to regulate fatty acid oxidation. So here you're within mitochondria, and the PPR receptors, alpha and beta, gets activated and oxidize free fatty acids. And those are when they are effective, the alpha and beta. But let's look when they are defective. What happens to the free fatty acid oxidation? Nothing is happening. Those are defective. So the free fatty acid accumulates in the liver. And you start getting fatty liver and hepatocytes accumulation, and looks at the PPRs. When they're defective, you get fatty liver and eventually inflammation as well as fibrosis. I told you about FXR and PPAR mechanism. Let's look at another drug mechanism, CCR. So again, fat accumulation in the liver, that's how the process starts, George. And then within the liver, after the fat accumulation, the CCR2 and CCR5 gets activated through their ligand. And they're started activating other cells, inflammatory cells, different kinds. Those are Kupffer cells. Kupffer cells start maturing and maturing. And then they release CCL2. And this secretion starts recruiting other sites. This one, the blue one, is like, hey, monocytes, come. I want you in the liver. And start pulling the monocytes to the liver. And the monocytes also mature into macrophages. And the same process you saw earlier in the liver. Macrophages and other inflammatory cells start releasing cytokines, and you get this inflammatory mallow in the liver, and that eventually leads to fibrosis, and you get this NASH and fibrotic liver. This is much cooler than Michael Jackson's song.
That's true. Okay, let's now get the slides back on. So let's actually start looking at the clinical data, and we'll start with OCA. This is the Flint study, which was basically carried out by the National Institute of Health in the United States. And I think, Rohit, you were part of that. And I think Arun Sanyal and a few others, Brent Tetry, all of these guys were a part of this study. And it turned out that the study that basically used OCA 25 milligram versus placebo had to be discontinued early because it did meet a number of histologic endpoints. So that actually led to the development of the phase 3 clinical trial. And of course, the phase 3 clinical trial that you've heard about is called Regenerate, and the design of Regenerate is right here. Now remember, Regenerate is actually an outcomes study. So this is going to take a very long time to actually get the actual outcome of the study. However, there was actually a pre-specified data analysis at month 18 with a second biopsy that was actually agreed upon with the regulatory bodies to look at the second biopsy in terms of surrogate endpoints. So in this study, about 2,400 patients were randomized to either placebo, OCA 10 milligram, or 25 milligram. And I'll also show you the expanded ITT analysis, which was actually presented this morning as an oral presentation. The endpoint was actually, primary endpoint was either resolution of steatohepatitis without worsening of fibrosis, or improvement of fibrosis by one stage without worsening steatohepatitis. So if you actually meet any one of these two criteria, the study was considered to be successful. This was what I actually presented at last EASL and in Vienna, looking at the primary ITT analysis, and here is the data on fibrosis improvement. And as you can see, there is actually the 25 milligram OCA certainly met the fibrosis improvement, and that was highly statistically significant. Although you can see that the p-value for the 10 milligram is also less than 0.05, but the pre-specified actually p-value was lower than that, and that it was not considered to be significant. On the other hand, when you look at fibrosis, when you look at steatohepatitis resolution without worsening of fibrosis, again in this analysis it wasn't met. I just want to point out to you that this quote-unquote steatohepatitis resolution was a very difficult endpoint to meet, meaning that not only you actually did not, you should not actually worsen fibrosis, NASH score has to improve, and you have to have a ballooning of 0 and law of inflammation, or law of inflammation of 0 or 1. So it's a very difficult endpoint to meet. Regardless of this, when you look at those patients and the different sort of regimens that you have that improve fibrosis versus those that worsen fibrosis, the 25 milligram arm has significantly more patients who improve fibrosis versus worsen fibrosis. If you look at the placebo at the bottom, you see that it's equal. It's basically, you get about 20% of patients improving and 20% of patients worsening. So this actually provided evidence that there's significant improvement of fibrosis in patients with NASH. And in fact, when those subgroup analysis was done, there was actually improvement in every subcategory. There was actually, in general, this was well tolerated. The side effects that was actually reported here were very consistent with FXR side effects or adverse events, itching, and which was mild in general, as well as the dyslipidemia that actually responded very well to treatment with statin. Now this morning, the entire study team, and all of us are a member of the study team, actually heard the presentation by Arun Sanyal looking at the expanded ITT. So the expanded ITT not only has the F2s and F3s that were included in the original ITT, now we have F1s with some risks. So they have to have some risk like obesity, type 2 diabetes, or they have, I think, the abnormal liver enzyme is the other one. So if they have that, they were also actually included. So there's a larger number of patients. When you look at this analysis, you see the same thing in terms of fibrosis improvement without worsening of steatohepatitis. When you look at now the second endpoint of steatosis resolution or resolution of steatohepatitis without worsening of fibrosis, now you see actually that there is actually improvement. Again, the side effect and adverse event profile was basically the same. So that's basically the OCA data, and of course we can discuss some questions at the end if there are anything. But what I'd like to do is to actually ask Rohit to come up and talk about the lefebvre, both GOLDEN and Resolve It.
Great, thank you, Zubair. Moving on to elafibranor. As you know, it's a PPAR alpha delta agonist, and it's orally available as well. The data that's the basis for the phase 3 program is the GOLDEN trial. In the GOLDEN trial, the inclusion criteria was patient had to have NASH, and they had to have features at least 1 point for ballooning, lobular inflammation, or steatosis. The patient came into the trial, and this was designed many years ago, as you know. And their primary endpoint was resolution of NASH, and it's shown to the left. The protocol-defined primary endpoint between the 2 doses for elafibranor, 80 and 120, relative to placebo, shown in gray, doesn't seem to be very significant. And one of the reasons for this was that at that time, we didn't have really guidance for who should be treated and who should be coming into a clinical trial among patients with biopsy-proven NASH. So once this trial was published, it was quickly realized that patients who have milder disease, the placebo response is very high, and it is difficult to show treatment effect delta with a therapeutic modality. And so a post-hoc analysis was done, and assessment was done in those who had a NAFLD activity score of 4 or higher to begin with. And then you could see a separation, 19% resolution of NASH with the 120 milligram dose versus 12% on placebo. And that's the genesis of the data and design of the Resolve It trial, which is a randomized placebo-controlled trial with placebo versus the 120 milligram elafibranor dose, which is under investigation currently. So hopefully in the next few months, we will know the results of these data and then know the efficacy of this particular modality. The primary endpoint for this trial is resolution of NASH with no worsening of fibrosis. And resolution of NASH now in this trial is defined as getting to lobular inflammation of either 0 or 1. And the grade for lobular inflammation is graded from 0 to 3. And ballooning score of 0. And ballooning is typically graded from 0, 1, and 2. So hopefully, we'll be receiving the results of this trial pretty soon.
So I'm going to ask actually Mazen to actually give us some of the data on scenic curve rock, on Aurora, and also on Centaur.
So I'm going to talk about CVC. As Dr. Younasi mentioned, the Centaur trial was already published. This is the phase 2 trial, and this is the design of the trial. You see it in the bottom. So it was 2-arm study, 150 milligram of CVC, and the placebo of the bottom. And here the published data so far is the 1-year biopsy data. So they did biopsy at screening and 1-year biopsy. And they presented the follow-up biopsy data in EASL previously, but I'm presenting here the published data. So again, I'm presenting the 12 months data. On the top, you see improvement in 2 points of NASH, and they did not meet that, so no effects on the steatohepatitis. On the right, which is where the money is, if you look at the left side of the figure, so they did not meet the point of resolution of NASH. However, what they met in that study, improvement in fibrosis in 20% of the patients at 1-year biopsy compared to placebo of 10%, and that was the rationale in advancing them to phase 3 trial, which we're waiting the study results for, and I'll pass it back to you.
Great, thanks, Mazen. Let me just actually now go to the last drug that we're going to discuss here, it's lonsertib, which is an ASK1 inhibitor. As you know, the phase 2 was actually presented by my esteemed colleague, Dr. Lumba here. And in fact, actually, there was a lot of interest in this drug because it did improve both fibrosis and also reduced progression to cirrhosis at 24 weeks, and 2 different doses that were used for this drug. Of course, that was taken on to really 2 very large clinical trials for patients with advanced fibrosis. It was Stellar 3 and Stellar 4. And a press release, of course, was initially released by Gilead Sciences for Stellar 4. That was actually a negative study, and also for Stellar 3. This is actually the data that was presented again today by Steve Harrison to represent all of us. Again, all of us were part of this study. So to my left, your right, you see basically the STELLAR-3, and you see basically placebo and the two other arms of active drugs with selonsertib. Now, I remember the endpoint of this study was actually improvement of fibrosis by one stage. And actually both studies had similar endpoints, and although in the STELLAR-4 there was also adverse events that was going to be counted. In both STELLAR-3 and STELLAR-4, there was no actually difference between the placebo and the two arms of the drug. And at the moment, this, of course, this specific regimen has been discontinued. Now, there is also some opportunity to change liver fat, and that can be assessed by MRI-PDFF, and that has been applied in some of the phase 2 clinical trial, including the phase 2 selonsertib study. So I'm going to ask Rohit to come and actually again talk about this technology and then apply it to two of the agents that are actually being used. Rohit.
Thank you, Zubair. Several years ago, we developed a fat mapping protocol at UCSD to assess treatment response, and I'm just showing you an example of that. You have week 0 data to the left, and then week 24 to the right of a patient treated in a treatment trial, and we're showing you MRI-PDFF result. The key thing we found was the fat in the liver was heterogeneous, so it was important to look at the same spot before and after. So what we do is we create 9 regions of interest, one for each segment in the liver, and look at the same spot before and after. And by this co-localization, we could improve the accuracy and the precision of the exam, so you could do shorter trial in shorter time period and improve efficiency of treatment response assessment, whether you want to move the agent to a larger biopsy-based trial in future. Actually, Mazen has worked on this as well, and one of his papers showed that MRI-PDFF was better than histology in predicting changes in liver fat over 24 weeks, especially if the liver fat content only changed by 5%. Since then, this question comes up over the last 2-3 years. We've investigated that in multiple trials. What is a clinically significant reduction in MRI-PDFF? It's a surrogate of a surrogate marker, but I think we still want to know if a patient is improving in the setting of a trial, whether this drug is acting on the target, if it is supposed to lower hepatic steatosis, should we move it forward to a larger biopsy-based trial? And this data actually came from a post-hoc analysis of 2 of our investigator-initiated studies at UCSD. We looked at histologic responders, and we had paired MRI-PDFF data on them, and histologic non-responders defined a 2-point improvement in NAFLD activity score. And what we found was a difference of about 30% in MRI-PDFF was associated with 2-point improvement in NAFLD activity score. So we proposed that. This paper was not easy to publish, as you can see where it was published. But since then, we have validated these data in 4 different trials, and you can see many of the trials are actually reporting data with a 30% PDFF reduction as a surrogate for taking it forward for clinical development. Here I'm going to give you one example using pegbelfermin, which is a FGF21, pegylated FGF21 analog. FGF21 is a moiety that's associated with beiging of fat. You might have heard that you could potentially modify the fat burning capacity of brown fat versus white fat, and you could convert that, and potentially this could be achieved with FGF21. Other ways FGF21 may be improving hepatic steatosis, inflammation, and potentially fibrosis is by increasing adiponectin levels, and adiponectin levels may have an effect on improving liver disease. In addition, it's known to reduce hepatic steatosis in animal models, so we designed a trial with a group of investigators looking at patients with biopsy-proven NASH stage 1 to 3 fibrosis who underwent MRI-PDFF at baseline and MR elastography and repeated that at 16 weeks. And I'm just showing you data. The primary outcome here was change in MRI-PDFF, and that's why I explained as to what would be clinically important earlier. So you're getting about 6.8% absolute reduction, and the relative reduction in this particular trial is ranging between 50 to 60% compared to placebo. So this program has now moved to a phase 2b trial where biopsies are happening in patients with stage 3 fibrosis and separately in a stage 4 fibrosis trial before and after, along with paired MRI and MRE assessment. This is NGM282, which is FGF19. It's a synthetic FGF19. It's a gut hormone-derived moiety, and we all have it. And if you consume food, bile acids are released. Bile acids may activate these TGR5 receptors and FXR in the intestine together. The activation of FXR in the intestine may release FGF19, goes to the liver, shuts down bile acid synthesis. So FGF19 in this particular trial was assessed for reducing MRI-PDFF in a 12-week trial. And what we found was that a 6 milligram dose relative to 3 milligram dose relative to placebo led to 60% reduction in MRI-PDFF relative to baseline. This is a pretty significant reduction, and that was associated with improvement in ALT and also improvement in AST. And I'm just showing you an example of a patient who had a baseline MRI of about 24%, went down to MRI-PDFF of 3.6%, which is normal. So both of those programs have now moved into biopsy-based 2B studies. This is looking at resmetirom. This is a thyroid hormone beta receptor agonist. The way this modality works is you can activate beta oxidation in the hepatocyte, and as Mazen nicely showed here, the animation, you could improve the lipotoxic signals or species related to lipid accumulation in the liver by burning of that, by activating beta oxidation in the liver. This leads to a reduction in hepatic steatosis. And I'm showing you data from week 12 in this particular phase 2B trial. They had patients with biopsy-proven NASH who had stage 1 to 3 fibrosis. And at week 12, they repeated the MRI-PDFF, and they also had MRI-PDFF at baseline. And you can see they also had a greater than 30% reduction in MRI-PDFF at week 12 with the treatment dose, and that was sustained at week 36. That was end of treatment. At the end of treatment at week 36, the patient underwent a repeat biopsy. And what they found was that numerically there was greater 2-point improvement in NAFLD activity score in patients treated with resmetirom compared to placebo. And there were significantly higher NASH resolution in the treatment group relative to placebo, 27% versus 6%. So this has now moved to a phase 3 program.
All right, so I think we're going to just close with what is, I think, probably going to be the future of treatment of non-alcoholic steatohepatitis. Of course, you have to find the high-risk patients, and that's NASH and probably NASH with some fibrosis. But it's really going to be a combination of multiple drugs because it's such a heterogeneous disease that multiple targets are involved, so you probably have to go after multiple targets. This is one combination that's going to actually probably be available in terms of the results by hopefully early next year. It's an ASK1 inhibitor, a PPAR, and also a chemokine CCR2, CCR5 sort of combination that's going to be put together. The one that I was actually alluding to is this one from Gilead Sciences that Rohit, I think Eric Lawitz presented that, but I think I'm hoping that the result of this will be available. So there are two things, at least I'm biased on that, and I'd like to hear my colleagues here, is that there are two things that's going to be important for this disease. One, I think is going to be a combination, at least for a short period of time, even maybe a year and a half. Second, this is not hepatitis C. You can't actually treat this disease for 6 months or a year and a half. This is going to be treated like diabetes, meaning that you're going to have some form of treatment for life, unless you're miraculously going to cure their diabetes and they're going to all lose weight and sustain that. So we'll have to have something that's going to sustain the improvement that we'll have, and we'll have to see whether that will be. So let me just actually summarize before getting to the question and answer sort of session, to tell you that identifying risk factors and using the markers that are available in terms of disease progression to risk stratify patients would be important. Also applying some of the non-invasive tests and prognostic tests that Rohit talked about to again find those patients and bring them to and link them to your subsequent care. And also it's very important to stay current on the latest clinical trial evidence, and hopefully some of the drugs that are going through phase 3 will become available soon, so that we have some options for our patients. We're going to stop here with the formal presentation, but there are plenty of actually questions here, very interesting questions that I'm going to actually take on. And I'm going to start actually asking you, Rohit, when do we have to start screening people? Do we screen? Should we screen general population, or should we do sort of risk stratification or case finding? And what tests do you use in clinical practice?
Yeah, I think I want to start with a high-risk group, and this would involve changing clinical practice and developing evidence. So there are two groups of patients where I'm starting with. One is a 50-year-old type 2 diabetic, and we're prospectively studying this group. We have screened about 370 patients so far who are 50 and type 2 diabetic, and we think the prevalence of advanced fibrosis based upon advanced imaging modalities is about 10%. So 1 in 10 would have disease, and I think that would be cost effective if we were to roll it out for assessment. So I think that's one group I would assess, and screening is for advanced fibrosis, not for NAFLD. The other group, Zubair, as you know, is those who have a family history of cirrhosis. So when I see a patient who has NASH cirrhosis, I screen their family member free of cost, and we've set up a research program. So we do advanced MRI on them, and it could be 1 first-degree relative or 10. What we are finding, and these data are published, that 18% of the first-degree relatives have advanced fibrosis that they're unaware of. So I think those are the two groups currently that I am thinking about screening for advanced fibrosis.
Yeah, and I think it's important to actually clarify screening from case finding, because both AASLD and also EASL do not really recommend general population screening. We're talking about here high-risk population and really case finding, which is very, very important. And also, of course, it's important that to recognize that screening tools have to have certain characteristics, that they have to be available, accessible, easy, cheap, and there should be a treatment available. And of course, I believe there is treatment available. Weight loss is a treatment. We just are not very successful at it, but that actually is, certainly is available. How about a question for you, Mazen? Lean NAFLD. Tell us, do you think that lean NAFLD in general, I'm not talking about specific sort of groups, is it just early, just NAFLD?
No, I don't think it's an early NAFLD. You had a lot of data, other people had a lot of data. I think it's a different NAFLD. And I'm sure it's in your clinic, and I have to stand up like you guys.
You can do whatever you want.
it's different, and I'm sure you all have seen these patients. I get a lot of Asian patients, and I get a lot of Indian patients, and they're lean. They come with a little bit stomach, that it's the metabolic syndrome and insulin resistant. And I have seen a lot of them with advanced fibrosis and cirrhosis. So I don't think all of them are actually early NAFLD, rather it's a separate signature that it has their own features, including advanced fibrosis and cirrhosis. And indeed, many of those, they come to me and they say, many patients, they don't want to go into clinical trials, and they say, I don't want to be guinea pig, and I don't want to go into your clinical trials. But these lean patients, they come and I do transient elastography or FIB4 or NFS or MRE or liver biopsy, and I find F3, and then I sit with them and I'm like, then what?
Yeah.
you cannot lose weight.
Yeah.
So those are patients actually the most applicable candidates for pharmacological therapies.
Yeah.
And you presented some data in this meeting
Yeah.
on lean people. So you've
You know,
been-
I think in general, there is probably a group of patients that are lean NAFLD that will have a completely different pathogenesis, and I think I agree with that. But if you look at the United States and look at the enhanced database, and you look at lean NAFLD and you compare them to lean control without NAFLD, they're actually slightly more metabolically abnormal. They have a little bit more insulin-resistant type 2 diabetes. If you compare them to the obese or to overweight, they're less metabolically abnormal. So there may be this, at least Arun always argues that these are just early phases of younger patients with lean NAFLD. I don't believe that that's entirely the case, but I think some of them may have this group. One thing that I do now for my lean NAFLD is actually ask them to exercise and also make sure that they don't have visceral obesity. So they may actually have the right BMI. But if you actually do maybe what Rohit is going to probably create next, which is total body MRI to see where the fat compartments are, maybe you'll see more visceral fat that they can actually benefit from, even a small amount of weight loss. What do you think, Rohit?
I agree. I think one of the things that we're interested in is whole body fat and muscle depots, and assess them longitudinally as patients lose weight or gain weight, and as they develop fibrosis progression, what happens to their total muscle mass and visceral fat. So I think all those would be important. I do, for my lean NAFLD patient, is I take a very detailed history of alcohol use, and I ask them to stop it. And that's number one for me. I look for medications that they may be exposed to, look for family history, look for potential genetic diseases that may not have been discovered, and take a detailed history of their diet. They sometimes have dietary restrictions. But one thing that we found from the Pivens trial, if you had lean NASH, you had a pretty decent response to vitamin E. It wasn't any different or less compared to those who had advanced obesity or high BMI. So I think they should be responsive to therapy, and I agree they should be offered treatment.
Yeah.
And exercise would be a great option.
Yeah, now the exercise, I think, which is the other compartment of insulin sort of metabolism, is going to be a major issue.
Actually, also one good example is
Yeah.
from the diabetes literature,
Yeah.
and there have been recent papers breaking down the diabetics.
Yes.
There's diabetic obese
Yes.
that is healthy,
Yes.
and diabetic obese that has cardiovascular profile and all that. And there's the lean diabetic who is healthy, and there's the lean diabetic who's unhealthy. So I wonder if the story of these lean NAFLD and the obese NAFLD will evolve into the same thing. The obese people have very high prevalence of NAFLD, but there's that part, the small part, that they don't get NAFLD. So we're not sure what's their story.
Let me actually ask you a controversial question. Obesity and actually type 2 diabetes is very high in African Americans, but they don't have a lot of NASH. Why?
Yeah. Well, I think this is an important area of research. One of the things, at least from the Dallas Heart Study, it's clear that they don't have the risk allele, which is the PNPLA3 genotype, and that might tell us that if you look at African American population, they have high risk of hypertriglyceridemia, they have high risk for type 2 diabetes, but the risk of storing fat in the liver is much lower. So that's one potential application or possibility, but I think there might be others. It is also possible, I don't think that data is there, and the reason why that data is not there is because most of the GWAS studies have been done in Caucasian populations. That potentially they may have overrepresentation of HSD 17B13, maybe they have some protection built in. So.
And as he alluded, the distribution of fat, some people say the
Yes.
fat is distributed
Definitely.
downward
Yes.
rather than
Yeah.
centrally.
Yeah. Yeah.
But I want to emphasize, they're not protected completely. Some people, they say they're protected.
Yes.
We publish data in hepatology. Kenkusi published data. It's not protected. It's common, but not as common
No,
as
that's
all.
common in Caucasians, absolutely. So there was a question about what about liraglutide, and I'm going to just say that GLP-1s in general are probably going to be one of the hottest drugs for treatment of NAFLD and NASH. Not only because, and of course there is some data suggesting that there is going to be a decrease in liver enzymes, and there's a phase 3 that's going to start with semaglutide. There are other GLP-1s that are going to probably will be similar. In my view, the reason is that it's not only the liver part, it's the cardioprotection part. Because the number one killer of patients with non-alcoholic fatty liver disease is cardiovascular mortality. If you have a drug that can actually reduce weight, the source of the problem, improve insulin resistance, that can also actually provide not only liver protection, but actually cardiovascular protection, I think that would be an incredible sort of opportunity for us. But then you just have to see what the side effect profile is, how long people can actually last, and our patient with fatty liver disease is going to inject themselves once a week. Those are some of the issues that we hopefully will get in sort of the clinical trial. Weight loss. Why are we not actually focusing on weight loss drugs? Not just GLP-1s. Others. There are plenty of others. Weight loss is effective if you lose weight. Bariatric surgery is very effective if you actually maintain it, and it's been shown. So why we're not just developing something that would be completely focused on the source of the problem, the weight problem?
I think the weight loss therapies have not been satisfactory, and they come with their own baggage. There are certain weight loss therapies that may have an increased sympathetic tone, and that potentially could have, and at least in the short term, some CVD risk. Our patients are hypertensive, have a prevalent CVD, not only incident CVD, which means they may have significant heart disease. It hasn't been precipitated. So there are certain medications that we tend not to prescribe to them. I think GLP-1s could potentially be used in our patient population, especially if they were diabetic or obese. There is associated nausea that might be restrictive. The others, such as SGLT2, I think have been used in patients who have type 2 diabetes and obesity, and they can provide modest weight loss. I think the issue is tolerability and the degree of weight loss. Yeah. I think outside of GLP-1, the amount and degree of weight loss is not big enough to induce improvement in hepatic fibrosis. But I think all would be beneficial.
I cannot agree more. I mean, the margin of approval for these drugs is very low. Yeah. And the question is, you show the data when you have F3 that's going to progress to F4 in 1 and 5 in 2 years. Yes. Am I going to wait on this marginal weight loss effect to reverse fibrosis and just rely on one drug? Yeah. And it's back to your, discussion. Yeah. This is probably going to be a combination with others.
One quick question is about OCA. When OCA will be available, I can tell you that they are going through the paperwork. All of us are involved in some fashion with all these drugs. We're great. We have no discrimination. All of us are, the pharmaceutical company are our friends. But OCA, I think, will be available, I hope, by next year. Probably mid-year next year, but that's the regulatory bodies. I can't actually sort of 100% say anything on that. Let me actually ask you a question that I'd like to also give my opinion, but I'd like to ask you first, Mazen. Why? We talked about NAFLD being very common in the Middle East, and you and I are from the same area of the world. We have Mediterranean diet over there. So how come this is not protective?
Oh, that's an easy answer for me. That's fake Mediterranean diet. It's definitely not what they read about in the New England Journal. The good olive oil and all that. It's definitely. I mean, I've been there. I ate that food. It's actually the diet. I think it's the main cause. There's a lot of. I tell my patients there are multiple cultures affected by this. Asian, Indians, Middle Eastern, and I forgot what's the other one. They all eat rice. The Hispanics. Yes. They all eat rice. They all eat bread. It's essential in their food. So Middle Eastern, the pita bread and the rice, they have it like 3-4 times a day. And the carbs, we know, like it's highly prevalent and highly high risk for these people. Diabetes is very high risk in the Middle East. So
what actually boggled my mind, if you actually look at the highest rate of increase in obesity in children, 4 or 5 out of the top 10 are in Middle East and the Mediterranean area. And that is exactly because of the diet changes that's been exported from the rest of the world. They don't actually eat the great food that our great grandfathers actually ate they eat hamburgers, cheeseburgers, McDonald's, and
That's
Pepsi
in
and
between
Coke.
the rice and pita bread.
That's right. That's right. I think that's basically all the time that we have tonight. I just wanted to end by asking my wonderful colleagues, Rohit, Mazen. It's been fun to work with you, and thank you all for staying here. And I'd like to also acknowledge and thank the CME Outfitters for the superb work that they have done to put this together. They really are top in the field and great in what they've done. I just also wanted to let you know that today's slides and presentation resources will be available and can be downloaded. I think there is that address that you see on the screen, and hopefully you can actually show some of these slides and share it with your colleagues, including some of the videos. With that, thank you again.